Dr. Wistinghausen's roles within the children's oncology group include serving as the principal co-investigator of a phase 2 study of rituximab and EBV specific T cells in patients with PTLD. And also, she is a responsible investigator for other 3 protocols on lymphoblastic lymphoma, B lymphoblastic lymphoma. Her clinical interests center around the treatment of childhood, adolescent, and young adult with non-Hodgkin lymphoma, histiocytosis, and leukemia. And then it's my pleasure to hear Dr. Wistinghausen talk about hemophagocytic lymphohistiocytosis today.
Thank you so much for this kind introduction. So I was tasked with covering the large topic of hemophagocytic lymphohistiocytosis, which from now on I will only refer to as HLH, and been given 20 minutes, so I'll do my best to get through this. I have nothing to disclose. So hemophagocytic lymphohistiocytosis is named after this very angry histiocyte who has engulfed numerous red blood cells, but hemophagocytosis is neither necessary for the diagnosis of HLH, nor is a prominent feature. So HLH is defined as a syndrome of extreme immune activation with an overwhelming inflammatory response, but loss of physiologic regulatory elements so that eventually it leads to end organ damage and death. It's characterized by the clinical findings of fever, cytopenia, splenomegaly, and coagulopathy, and was first described in 1952 in 2 siblings, then termed familial hemophagocytic reticulosis. It can either be caused by inherited defects in immune regulation, then called primary HLH, or be due to acquired defect, then called secondary HLH, either to infections, autoimmunity, malignancy, or more recently, also cellular therapy has been added to secondary HLH. This is a list of all the currently known primary causes of HLH, and that list expands constantly. They are the 4 mutations that were included in the familial HLH group, consisting of mutations in perforin, MONC 13.4, syntaxin 11, and MONC 18.2. The second group are the X-linked lymphoproliferative diseases, followed by the pigmentary disorders. More recently, inflammasome-related disorders such as NLOG mutations and CDC42 have been added. And there's an ever-growing list of immune disorders with EBV susceptibility where patients are at risk of HLH. The list of secondary triggers is even longer. It includes infectious trigger, most commonly viruses such as EBV, CMV, and HSV, parasites, most commonly leishmaniasis, bacterial triggers. There is the group of malignancy-associated HLH, most commonly due to lymphoid leukemias and non-Hodgkin's lymphomas. Autoimmune diseases can also trigger HLH, and as can CAR T therapy and other cellular therapies, which is, of course, a iatrogenic HLH. I took this quote out of a recent publication from the Journal of Critical Care Medicine, and it was a consensus statement, and their first consensus statement from HLH experts around the globe was that HLH should be suspected in all critical ill patients with unexplained or disproportionate inflammatory responses. And that rings very true. So how do we diagnose HLH? Our diagnostic criteria are imperfect. Most of us still follow the HLH criteria as per the HLH Protocol 2004, in adults, other scores have been developed, such as the H score, which is useful in critically ill adult, and the optimized HLH inflammatory index, which is useful in patients with malignancy-associated HLH. But for the most part in pediatrics, we still follow the HLH 2004 criteria, which require either molecular diagnosis of HLH or at least 5 out of the following 8 criteria, which are fever, splenomegaly, more than 2 lineages affected by cytopenias, triglyceridemia or hyperfibrinogenemia, hemophagocytosis in the bone marrow, spleen, lymph nodes or liver, a lower absent NK cell activity or ferritin, I apologize for the title, greater than 500, and an elevated soluble IL-2R receptor. However, we know that these criteria are neither specific nor sensitive. All of us know that some patients with HLH require therapy when they're not meeting 5 out of 8 criteria, and some other patients fulfill all criteria, however, don't really need treatment. So a lot of effort has been made to look at making these criteria more sensitive and more specific. This is a study looking at ferritin cutoff levels, and it basically said that the cutoff of 500 is probably not specific and sensitive enough. At a ferritin of greater than 2,000, we reach 70% specificity and 68% specificity. So it's much better to use higher ferritin levels for the diagnosis of HLH than the published level of 500. More importantly, when you get to ferritin levels greater 10,000, this is 96% specific for HLH. So at very high ferritin levels, your suspicion of HLH should be extremely high. Other groups have incorporated other cytokines into the diagnosis and explored how they can help us to distinguish HLH from other diseases. And looking at CXCL9, 10, and 11, which are markers of interferon pathway activities, the ratio is very high compared to IL-6. This is fairly specific for HLH. However, in an inverse ratio, sepsis is the more likely diagnosis. The Canna group out in Pittsburgh did the same study comparing CXCL9 to IL-18, and again, higher CXCL9 ratios were sensitive for diagnosing HLH, while an inverse ratio seemed to be more consistent with inflammasome activation as seen in macrophage activation syndrome, XIAP, and NLOG mutations. And then more recently, groups have tried to distinguish HLH from MIS-C, and there's also differences in cytokine patterns that we can use to distinguish the two of them. So we have developed other tools in addition to the HLH 2004 criteria. Another useful tool is flow cytometry, especially looking at the expression of CD107, perforin, and SAP and XIAP proteins. CD107 is translocated to the surface during the process of cytotoxic degranulation. So in patients with defects in the cytotoxic degranulation pathway, including UNC13D, STXBP2, CTSI-CN, RAP27A, LIST, and AP3B, CD107A surface expression is low. We can use perforin to diagnose perforin deficiency, and then in male patients where we're concerned about X-linked lymphoproliferative disease, expression patterns of SAP and XIAP may be helpful in making the diagnosis. So these tests are very helpful if in suspicion of primary HLH, because we can get them back with a turnaround time of 24 to 48 hours, while genetic testing may take us weeks to get the diagnosis back. So looking at all the new data we have collected, we came together in the North American Consortium of Histiocytic Disorders and recently published a HLH diagnostic strategy in patients who present with unexplained cytopenias or hepatitis or inflammatory central nervous disease. If any of those conditions present, a further investigation should be made into fever, hepatosplenomegaly. Do the patients have prior HLA-like episodes, or is there a family history? And if the answer is yes, a diagnostic workup is indicated, including the old HLH 2004 criteria, looking at CBC, fibrinogen, triglycerides, ferritin, and soluble IL-2R, but also expanding it to CXCL9 and to liver injury by looking at transaminases. If primary HLH is in the consideration, as it is in all pediatric patients, flow cytometry for perforin, CD107A, and in male patients, SAP and XIAP will be helpful. And then ancillary studies should be obtained to rule out secondary HLH, looking for lymphoma with imaging, looking for underlying immunodeficiency, and ruling out infections. Now, if all of this is confirmed, therapy is indicated, as is genetic testing, expanding it to a CNS workup, and then following the patient closely for progression or for response. There are some special situation and differential diagnoses in HLH. As we know, any identifiable underlying condition should be treated promptly, but the workup should not delay the initiation of HLA-directed therapy in critically ill patients, because these patients are at high risk for progression. It is, however, crucial to rule out ALL and lymphoma prior to starting steroid and chemotherapy. We do now know that fulminant liver failure can be the only presenting sign of HLH. In the newborn period, however, we have to distinguish it from gestational autoimmune liver disease. I will talk a little more about isolated CNS disease in a moment, but I also want to mention that prominent lymphadenopathy is not a typical sign of HLH, and that the ratio between ferritin and soluble IL-2R can also help in making the diagnosis. An extremely elevated soluble IL-2R without correlating elevations of ferritin is more commonly seen in lymphoma, while extremely elevated ferritins without elevations in soluble IL-2R can be point to an underlying primary immunodeficiencies, especially in infants. Before we go on to the treatment, we got to look at the pathophysiology of HLH. In the normal patient, the activation of the cytotoxic T cell happens when the immune synapses is built, and then an orderly degranulation happens with release of granules. The perforin 4 will build, and they will enter the target cells. In HLH, this mechanism is disrupted, leading to production of interferon gamma, cleavage of soluble IL-2R into the plasma, and then secondary production of many inflammatory cytokines that feed the fire of HLH. In EBV-related HLH, the mechanism is slightly different, in as that the infected B cell triggers the cytotoxic T cells, and there's again a limit to how much the cytotoxic T cell can control their activation. So the principles of therapy is to promptly dampen the cytokine storm and eliminate the activated T cell and macrophage population. We do know that rapid initiation of therapy is life-saving in patients with primary HLH and in some patients with secondary HLH to avoid an organ damage and failure. However, we also know that not all patients with secondary HLH require prompt initiation of therapy. So treatment decisions really need to be made on the severity of clinical disease and the progressive course, not strictly on the 5 out of 8 HLH criteria, which are helpful just to make the diagnosis and see where your patient stands, but they then are also helpful to follow over time to see what is the trajectory of your patients. The standard of care remains HLH-94, which consists of a combination of dexamethasone and etoposide that is then slowly weaned over the course of a couple of weeks. IT therapy in patients, intrathecal therapy in patients who have CNS involvement is added on week 2. That is due to the fact that a lot of patients are too critically ill to start it at the beginning. And a lot of patients who present with CNS disease actually resolve just by giving them dexamethasone and etoposide, so they may end up not needing intrathecal therapy. HLH-94 was followed up by HLH-2004, which added cyclosporin to the treatment plan. Cyclosporin did not add an improved outcome in patients with HLH. However, some investigators still find it helpful to add as the wean starts to prolong basically the remission from HLH. Now, I do get a lot of pushback in a non-malignant disease about using chemotherapy. So are there any novel therapies that we can use? I'm going to skip over the approach to therapy being more nuanced in the interest of time and get back to CNS HLH in 1 second after I've done my novel therapies. So what do we have in terms of novel therapies? We can do a more targeted elimination of macrophages, NK cells, and T cells by using alemtuzumab, which is an anti-CD52 antibody. And there is a phase 2 study in 22 patients with refractory HLH, which showed 17 survived to transplant and 15 remained alive after transplant. However, alemtuzumab has a high risk of viral infections, and I would argue that etoposide is probably a more benign agent. Interleukin-1 inhibition has been used with anakinra. It's probably more efficacious in macrophage activation syndrome and has been shown to have poor outcomes in EBV-related HLH. Interleukin-6 inhibition with tocilizumab plays more a role in cytokine release syndrome in association with CAR-T and BiTE therapy. The interleukin-18 inhibition with catechinate alpha is currently in clinical trial in patients with disorders of the inflammasome, and I'm looking forward to those results being released because it seems to be very active in XIAP and NLRP deficiencies. But there are also 2 agents on the horizon for HLH, mainly using interferon gamma inhibition and JAK-STAT pathway blockade. And mapalumab, which we've heard about previously from Dr. Welts, is a monoclonal against interferon gamma. And results of a phase 2 study in patients with primary HLH that either hadn't been previously treated or was refractory have recently been published in the New England Journal of medicine and show a very promising overall response of about 60 to 65%, and an even more impressive overall survival, close to 80%, in both previously treated patients and patients who hadn't been previously treated. So imatinib is currently FDA approved in refractory primary HLH, but it'll be interesting to see it to come up to the frontline treatment. Another agent is ruxolitinib, which is a JAK-STAT inhibitor leading to a reduction of pro-inflammatory cytokine production. Many cytokines signal through the JAK-STAT pathway and lead to production of additional cytokines, fueling the fire of HLH. Favorable responses have been described in refractory patients with response rates up to 73 to 100%. And as one of the founding institutions of the North American Consortium for Histiocytic Disorder, we are part in the development and the running of HLH Ruxo, which is a phase 1b/2 study of ruxolitinib combined with dexamethasone, and in the safety phase, also combined with etoposide for newly diagnosed and refractory patients with HLH. This study should be open to enrollment at Children's within the next months, and we're very excited to enroll our first patients. I'm going to skip, in the interest of time, over hematopoietic stem cell transplantation and quickly mention what we're doing here at Children's Hospital. So we have an histiocytosis registry open to document the natural history of histiocytic disorders. We recently formed a multidisciplinary HLH group, including hematologists, oncologists, neurologists, immunologists, bone marrow transplanters, and infectious disease specialists, to develop evidence-based guidelines across all specialties, and to harmonize our workup across the spectrum of inflammatory diseases. And this is especially important because of the overlap of HLH with some of the neuroinflammatory diseases Dr. Wells earlier spoke about. And we also want to function as a resource to the children's community. And then we're offering cutting-edge therapy with HLH Ruxo. We have been successful in getting approval for imatinib, including in the patient Dr. Wells described earlier, and we're offering bone marrow transplant. And I'm sorry I went a little over, but thank you for giving me the opportunity to speak.